Sandy Magnan Institute for Clinical Systems Improvement. So you left us hanging there. You said we need policy to reinforce this trend.
What should
So
we do?
what should we do?
All right.
And what should be the role of the Population Health Roundtable in reinforcing the correct policies?
Okay, so there are two categories of things we can do. This requires us to figure out why we think this is happening. And here, so everything I put up there, I have a high degree of conviction on because it's factual. Now I'm out over my ski tips because frankly, no one really knows. I just want to be clear. Okay, so here's my speculation as to why this is happening. And let me start with a vignette. I'm on the board at Mount Sinai in New York, Mount Sinai Hospital. Mount Sinai, like many other hospital systems in the US, has succeeded in reducing readmission rates. So you're in the hospital, you're discharged from the hospital, 20% of you wind up back in the hospital within 30 days. Not rocket science in general to reduce that. Mount Sinai put in place an algorithm to predict who's at highest risk, so-called PACT program, puts a social worker on that person, make sure they take their medication, make sure they show up for their doctor's appointments, 50% reduction in ER visits, 50% reduction in readmit rates. Here's why this is an interesting vignette. Right now, that program, which is a wonderful thing, because who wants to get readmitted unnecessarily, is losing Mount Sinai a ton of money. Why is that? Well, reducing readmissions helps to avoid a penalty that we put in as part of the Affordable Care Act on high readmission rates, but that's small relative to the fact that, and the social workers cost a little bit, those are both small effects. Basically, the key driver is under current payment policy, every time someone's readmitted to the hospital gets paid. So when you reduce readmission rates, you're shooting yourself in the foot financially. By the way, that's crazy. So, so why is Mount Sinai doing this? And this is why this is an interesting vignette. Of course, if you had Ken Davis, the CEO here, he would say, because we're a benevolent organization and we like to do the right thing, which is part of the truth. But another part of the truth, and in fairness, even if you're a benevolent organization, if you're bleeding money on this program, that means you can't spend it on something else. So it's not quite so easy even in that situation. The real reason is that the organization believes that within 3 to 5 years, the financial incentives will flip. And running an academic medical center is like a carrier, and you got to start turning the ship now. So they're kind of practicing for where they think the payment system will be. And that's consistent with surveys of most hospital execs that suggest they're going to get paid differently in 5 years. What payment are we talking about? Something like the alternative quality contract in Massachusetts, where it's close to, it might not be fully, but it's close to a capitated payment. So if I'm a hospital, I'm getting $10,000 per year to take care of all the care you need, then any readmission comes out of my bottom line instead of adding to it. Completely flips the incentives on their head. So herein lies the difficulty. If a lot of this is being done on expectations of future price payment reform, backed up by the fact that the system is digitizing so I can manage against that now, if we don't then fulfill those expectations, people are going to drop these programs. And so we're at this moment now where everyone kind of thinks we're kind of going this way towards value-based payment and away from fee-for-service, and that's all great, but there's no clarity about how quickly we're going to go there. There's almost no clarity about exactly what model. Is it the Accountable Care Organization 2.0? Is it bundled payment? What is it? And so it's kind of a blob, and that's fine because you're starting to turn the aircraft carrier and the blob's over there. But at some point, the blob has to become real and specific. And so we are at a moment where policymakers need to provide a glide path in terms of how we transition away from fee-for-service and exactly how that's going to work. And my utter frustration here is that, ironically, both Democrats and Republicans agree on that proposition. In fact, it goes beyond that agreement. Everyone agrees we need to move away from fee-for-service payment. Pretty much everyone agrees we're going to have a risk-adjusted, capitated type payment up front with a quality adjuster at the back end. That's great. That's like apple pie among health wonks. That's terrific. The problem is basically Republicans want that payment to go to an insurance company who will then contract with providers to make it a reality. The Democrats want it to go directly to the provider. That's the big difference. The irony in that is, as private insurance companies are moving in this direction anyway, the dividing line between a provider and a payer is becoming quite blurry, because if I'm facing private incentives that are capitated, $10,000 per person outside of Medicare, like the alternative quality contract, I'm sort of becoming an insurance company. I'm at risk for utilization. I'm at population health risk, and I'm at utilization risk. So I know that was a long answer, but that's one of the most important things we could do. Another thing which is relevant to this world is we are just at the beginning of the population health revolution, where providers are, the hospitals and doctors are incentivized and involved, and employers too, in that shift. And I'm kind of getting distracted by the blinking red light. Like,
we have time.
Okay. But there's a lot more that we could be doing there also, integrating, all these great data into something that's more useful, making sure that employers have the proper incentives, the research underscoring that. I mean, I'll give you one tiny research question that came up the other day. I'm not aware, although I have a strong behavioral bias towards believing that just like a small impediment to signing up for a 401k has massive effects on behavior, that a small impediment to exercising has a significant impediment or has a significant effect on actual exercise behavior, which is to say if the gym is in the building and very easy for a busy professional, that's a much different thing than if you have to leave the building, it's 6 blocks away, you got to change there, et cetera, et cetera. To my knowledge, no one has demonstrated that, but that's the kind of thing that corporate America, if there were a compelling study suggesting actually having the gym in the building makes a massive difference, then you could imagine a movement to make sure that every major workplace had not only a healthy cafeteria, but also a gym. But right now we're kind of lacking that information.
I have a question.
Sure.
So I'm going to take the next question, and also this is such a great opportunity. We'll take a few minutes to get most of your questions answered. So is there any policy history that would give us optimism that if those healthcare savings can be achieved in the optimistic way that you portray, that they actually might be redirected to some of the other social investments that we talked about in education and other parts of the population health investment question?
Yeah. So at the state and local level, I think this is mostly a game of trying to, stop the bleeding and make sure that the process that we've seen where state appropriations for higher education just is on a seminal long-term decline, that stops. I do think that would happen organically if the pressure on state budgets from health spending were attenuated, because no one likes to do the ratchet. And so if you could kind of eliminate the underlying driver there or attenuate it, I think it without any new policy intervention, it would at least kind of maintain stability. That's a different thing than increasing appropriations, which I don't really have a plausible scenario for. On the federal level, and I probably should have said this at the beginning, I am extremely concerned that basically the way we've played a game. I mean, I know this is on the record, but whatever. We've basically played a game where neither side wanted to own up to the revenue base that is required to finance everything that the federal government is currently being asked to do. Because the revenue base is inadequate, and because policymakers don't like to have big deficit numbers on deficit projection charts, the only way you can make that math work, given that Medicare, Medicaid, and Social Security are our entitlements and are automatic, is by taking the category that you have the most discretion about, the discretionary part of the budget, and try to make that the residual, the plug, that makes all the numbers work. And that's exactly what we've done. The problem with that is that we've adopted caps on discretionary spending, including education, including NIH, et cetera, that out in 2020, I think are completely and totally unrealistic. And it makes the numbers on a CBO or OMB set of deficit projections look nice, but they're just, they literally are simply caps. There's no bottom up analysis. It's just, it will be X. I mean, why X? Why not, we're on track for the lowest share of GDP since 1962. Why stop by 1% of GDP? Why not stop there? Let's do it minus 3% of GDP. We could claim that we're going to spend $100 on national defense in 2022. And an indication of that is in the very first year, this last fiscal year negotiation, very first year of these caps, over a $20 billion difference, which is nothing relative to the 2020 gaps that are assumed in these caps. There was a huge fight, and we ultimately kind of undid. So the bottom line is we're either the deficit forecast for the next decade are unrealistically optimistic because we actually won't implement the caps, which is actually where I think it will wind up, or we will implement the caps, and then the damage to a whole variety of different government spending programs is going to be pretty significant. A deceleration in healthcare would help to, even though technically there are different parts of the budget and it doesn't really it doesn't work from a technical perspective. In terms of the optics and the rhetoric, it would. If Medicare and Medicaid continue to slow sufficiently that you could have a little bit more room on the discretionary budget, it would help to avoid some of that harm. So I don't hold out any great hope for a massive new public investment program in education arising, but it's more in terms of avoiding future harm.
Okay, a couple more questions from roundtable members. George?
Yeah, thank you very much for that discussion. If you look at the chart of the OECD chart of where the U.S. stands relative to other advanced countries on that graph of life expectancy versus cost per capita, I'm assuming you're pretty familiar with that.
Yep.
Kaplan showed that Bob showed that just yesterday morning. We stand about twice the median cost per capita, and then maybe 3 or 4 years or so below the pack. In a recent IOM report, there was a recommendation that the Secretary HHS should adopt an interim life expectancy target, establish data systems for permanent health-adjusted life expectancy target, and establish a specific per capita health expenditure target to be achieved by 2030. And so it raises the question of shifting from a transactional sort of approach to an outcome sort of approach, where we should be on that graph and how that would relate to national competitiveness, economic competitiveness, obviously education, but also national defense and so forth out into the future. I'm just curious what you think about such an approach. John F. Kennedy put somebody on the moon by the end of the decade kind of approach where we would be setting some targets that then we would work backward from in terms of both increasing life expectancy for those of us who are interested in population health, but obviously in terms of reducing per capita expenditures to some level that might provide the resources to address some of the issues you've talked about in terms of how we're eating up education and so forth. Could you comment?
Sure. So 2 comments. First, before I get to the kind of benefit of aspirational goals and then some of the risks therein also. Just a comment on all the cross-country comparisons that are typically done. It's very interesting. The vast bulk of the difference in healthcare spending in the U.S. as a share of GDP or in real terms is because of price differences. It's not on average. I mean, we have this image that it's utilization. It's mostly price. The bulk of it is price. And yet, if you look within Medicare across the United States, where there's also a lot of variation, the bulk of that variation is utilization, not price. And so depending on which comparison you're doing, you can either get it to be, it's the price is stupid, as a famous paper once put it, with regard to the international comparisons, or why should the best healthcare in the world cost twice as much as the best healthcare in the world across different institutions within the United States, which is mostly based on the number of tests and the number of days in hospital and so on and so forth. So I think it's important to just recognize the variation, the cause of the variation depends on exactly what you're comparing. Now on the benefit of a goal, I think it's very important to have goals, and the more that they're outcomes and less process or intermediate, the better. And so for example, I think a good place to start would be to set a goal on that Medicare spending per beneficiary. And that therein lies, I guess, one issue with setting a goal. Yes, JFK said, let's get to the moon by blah, blah, blah. That was a fairly clear, objective. Obviously, it was complicated, but it did not involve as many things out of the control of the team that was dedicated to achieving it. And so one does have to be a little bit careful that you don't set goals over which, you have very little influence, because then it just undermines the whole perspective or the whole effort. So I would love to feel like we had enough influence over mortality rate trends to set a goal on life expectancy. I get a little bit nervous. I mean, that may be something. I would start by setting a target for total Medicare spending and then be clear about what happens when you don't hit that. And in fact, there were a variety of indirect ways in which that was attempted as part of the Affordable Care Act. But I think the Secretary at this point could be much clearer, at least on that. And then in general, at a lower level of kind of granularity, or kind of at a more granular level, the more that we can move payments to providers, physician groups, et cetera, towards outcomes there, the better, and set goals there. So I guess I'm a little bit nervous about just kind of setting a goal at a national level for something not fully under our control. On net, if a policymaker wanted to go do that, I'd stand up and cheer. I just, as a kind of researcher, I'm a little bit nervous about the degree of control that one has over mortality in particular.
If not, let's thank Peter very much for fascinating keynote. Thank you so much. So we're now got a lunch break. That clock is running 5 minutes ahead, as I think you've noticed. So we'll be back. Slow. So we'll be back in here at 1 o'clock real time. Lunch is in the lobby for everyone. And thanks for a great morning. Thanks to all of our presenters.
No.